anything. We have this survey about your feedback, how this session was. So please take 3 minutes to fill this for us. It's very important because we want always to be better for you. A little bit of Zoom education. So we don't want you to miss any part of the screen. Dr. Anderson has beautiful images, so it's important that you see the entire screen. So you go to view options and you check side-by-side mode, then you're going to be able to see all the screen. We want you to talk to us during this webinar. So when you use the chat to say hello, to say where are you from, or to comment anything, please click on all attendees and panelists so everybody can see what you are texting. And if you have questions, specific questions, please type them on Q&A box. We are going to read in the end of the session the most interesting ones. And if you want to make your question live to Dr. Anderson, just click on raise your hands in the end of the session. We are going to allow you to open your microphone and your video, and you're going to be able to discuss with Dr. Anderson directly. So our next activity, so we are going on the 3rd of August, we are going to have Dr. Silverman making a very good session correlating morphology and echocardiography images. So this next session is going to be about transposition of great arteries. We hope all of you can join. We have next Thursday our big masterclass. This is going to be very special in a subject that is very interesting. It's about sudden death and inhibited arrhythmia. So we hope all of you can join. It's going to be very nice. Dr. Mitchell Cohen is preparing a very interesting session. So please register for that and take your time to join us live on Thursday. You're going to be able to make questions and to see the discussion with all the specialists. And we have a discount for you. So Dr. Anderson was kind, and Dr. Gilvernovsky, who is the editor-in-chief of Dr. Anderson's pediatric cardiology textbook. So you just go to the Elsevier website and you enter the discount code Anderson35, and you're going to have 35% discount to have his book. And now we are going to start our session with Dr. Anderson, double outlet right ventricle. Just to remind you that we have more topics on this morphology series. So on the 7th of August, we're going to have transposition. Then we're going to have 1 week off. Then the next Friday, 21st of August, discordant AV connections. And then and the next one, 28th, we are going to have common arterial trunk. So thank you all of you for attending today. We are happy to have you here. And Dr. Anderson, thank you very, very much for being with us. This has been very good. We are learning a lot from you, all of us.
Well, thank you very much for that introduction, Grace. It's good to see so many people tuning in again. And today, very shortly, we're going to see my presentation on double outlet right ventricle. Now, this in itself is of interest because, as you all know, earlier this week, Meryl Cohen presented the echocardiographic aspects of double outlet right ventricle. So I have a confession to make. I was not watching Meryl's presentation, but I have been in touch with Norman Silverman, and Norman tells me it goes more or less with what I'm going to say, but we shall see. But at the end of the session, when Sasha has played for you the video, because as with previous weeks, we have pre-recorded my session, so we are sure it fits into the allotted time. I am going to be here and I am going to be ready to answer all your questions as to whether anything has transpired that needs clarification in terms of what Meryl said to you in terms of the echocardiography. But I'm going to be discussing with you today the underlying anatomy. And then it is of interest that on Tuesday of next week, Norman is going to be talking to you himself about transposition. And then at the end of next week, I shall be showing you the morphologic background. Now, I have little worry there that there will be discrepancies because, as you all know, Norman steals all of my images. And now he steals all of the images of Diane Spicer, which is the ones that I use. So I'm pretty confident that Norman and I will be telling you the same story. If there are problems with what you heard earlier in the week, I'm going to be here at the end of the session to answer all your questions. So now let's take you back to Sasha, who's going to play you today's recording on double outlet right ventricle. Well, good afternoon, ladies and gentlemen. Today, we're going to be discussing a situation in which, as you see from my opening image, the greater parts of the outflow tracts arise from the morphologically right ventricle. Now, this is the logical description for what we're going to call double outlet right ventricle. So why has this been such a problematic lesion in the past? Because in reality, it is no more than one type of ventricular arterial connection.
Okay, let's start again.
It follows, therefore, that we can find it in various atrial arrangements. We can find it with any atrioventricular connection. As I'll also emphasize at the end of my presentation, there can be varying relationships between the arterial trunks. The one point we have to emphasize from the outset, however, is that it cannot exist with another ventricular arterial connection. So no longer should anybody be talking about double outlet right ventricle with transposition, a combination we heard many times in the past. But the lesion, without question, has been controversial. I think for the large part, those controversies are outdated. I thought it had now been agreed that we no longer needed bilateral conuses to be part of the diagnosis, but I'm told that there are still those who would say in the presence of aortic to mitral fibrous continuity, we should assign the aorta to the left ventricle. And to me, that is a problem, and I will discuss that with you. The other controversy, which I hope is now a thing of the past, is whether double outlet right ventricle can coexist with tetralogy. So I'll also discuss with you the problems that existed in the past with that alleged combination. There is, however, one major ongoing controversy, and this we have to discuss at length, and that is whether it is justified to call the channel that we find in almost all the hearts between the ventricles a ventricular septal defect. It is my preference to call it an interventricular communication. And so I'm going to spend quite some time discussing why I think interventricular communication is a better descriptor than ventricular septal defect. But let's start with the problem that I thought was a thing of the past, whether we had to have bilateral infundibulums or bilateral conuses in order to diagnose double outlet right ventricle. Now, there are two major reasons why we should discard this notion. In the first instance, as I'm going to show you, in many instances, we can find hearts in which the arterial trunks unequivocally arise from the right ventricle, and yet still there is fibrous continuity between one of the atrioventricular valves and one of the arterial valves. So in that situation, to me, it makes no sense at all not to call that double outlet right ventricle. But there is another important reason why we should not be using bilateral conuses as the diagnostic feature of double outlet right ventricle. And that is because, on occasion, we can find hearts that have either concordant or discordant ventricular arterial connections, and there are bilateral infundibulums. So the reason we should not be using the infundibulum comes back to the principle that we call the morphological method. And this now is one of the major features we use when we're looking at the congenitally malformed heart. We do not use one feature, which is itself variable, in order to define another variable feature. And the person who established this key method was Richard van Praagh. He introduced the concept when he was criticizing one of our earlier papers when we were trying to disqualify the small ventricle in the setting of double inlet right ventricle from ventricular status. And he was 100% correct. And what Richard pointed out was that when we are analyzing congenitally malformed hearts, we should define the features in terms of their own intrinsic morphology. And this applies just as much to double outlet right ventricle as it does to double inlet left ventricle. And so what we're going to see is that infundibular morphology is but one of the variable features that we find when both arterial trunks arise from the right ventricle. So using the key concept established by Richard van Praagh, we should not be using the presence of bilateral infundibulums as a diagnostic feature of double outlet right ventricle, even when there is fibrous continuity between the leaflets of the aortic and mitral valves. And as I say, I'm going to return to that very shortly. But let's look at the other reason why we cannot use bilateral infundibulums as a diagnostic feature of double outlet right ventricle. Here I'm showing you the outflow tract of the left ventricle in the setting of transposition. So there you see the mitral valve that's coming into the morphologically left ventricle. It's a close-up picture of the outflow tract. And there, arising from the left ventricle in the setting of transposition, we have the pulmonary trunk. The aorta is arising on the other side of the ventricular septum from the morphologically right ventricle. But in this heart, as you see, there is an extensive infundibulum or conus that is interposing between the hinges of the pulmonary valve, the hinges of the mitral valve. Simply because we have bilateral infundibulums in this setting, we do not, I hope, argue that the heart is showing double outlet right ventricle. This is transposition in the setting of bilateral conuses or bilateral infundibulums. We define the features in terms of their own intrinsic anatomy. So what about the combination with Tetralogy of Fallot? Well, what I've already emphasized to you is that double outlet right ventricle is no more than a ventriculo-arterial connection. It is the situation in which the larger part of both arterial trunks arise from the morphologically right ventricle. Tetralogy of Fallot, in contrast, as we saw in one of our recent classrooms, is defined on the basis of the phenotypic morphology. So the two can coexist. And indeed, when we were discussing tetralogy, I pointed out to you that in the original description of Arthur Louis-Etienne Fallot, he described in detail how one of the hearts that came to his attention had the aorta exclusively arising from the morphologically right ventricle, even though the phenotypic morphology of the sub-pulmonary outflow tract was that of Tetralogy of Fallot. So in most instances, we have Tetralogy of Fallot with concordant ventricular arterial connections, but on occasion, we can have Tetralogy of Fallot with double outlet ventricular arterial connection. So the real problem is not so much dealing with those controversies, but rather how do we deal with the situation in which one or other of the arterial valves is overriding the crest of the muscular septum. And the answer to this is that we need to distinguish between those patients in which the degree of override is such that the outlets arise from separate ventricles despite minimal overriding, as opposed to the situation in which, despite the overriding, both outlets essentially are supported by the same ventricle. there will be a spectrum between these extremes, and what we have to do is to arbitrate that spectrum according to the 50% rule. And that itself has been controversial, and it is largely because people have been trying to arbitrate that difference on the basis of the long axis of the ventricular septum. Whereas, as I'm going to show you very shortly, what they should have been doing is arbitrating on the basis of the short axis of the ventricular mass. So let me illustrate that point to you. Here I am showing you a drawing of the long axis of the ventricular mass. And as you see, we've shown an arterial root that is overriding the crest of the muscular ventricular septum. Now, those who point out the problems when we try to arbitrate on the basis of the long axis point out that during the cardiac cycle, the orientation of the long axis will often move from a plane shown here by AA to another plane, BB. And during the cardiac cycle, it's possible to argue that the overriding root is arising largely from the right ventricle or largely from the left ventricle. But the point that is missed when using the long axis is that the relationship of the overriding arterial root relative to the crest of the ventricular septum, which is our arbitrating point, does not change when we assess the situation in the short axis. So let's look at what happens when we try to assess things in the short axis of the ventricular mass. Now, there is another potential problem, because if we look into the normal heart, it is a fact. When we look from the apex of the ventricular mass towards the base, then the aortic root, even in the normal heart, seems to ride the ventricular septum. But the essence of normality is that the ventricular septum is intact. And when we look at it in detail, in fact, as we look now in this anatomic specimen, when I'm showing you the normal heart, now, of course, I've taken the picture from the other side, so we're looking down on the aortic root. You're seeing the left side to your left hand, the right side to your right hand. There is the overriding aortic root, but it is the sinus of the right coronary component of the root that is overriding rather than the valvular leaflet itself. Because of necessity, in the normal situation, the right coronary leaflet is attached to the ventricular septum such that the aortic root is exclusively arising from the left ventricle, despite the fact that the sinus is overriding. And we can now see that in the clinical situation. So here is one of the exquisite pictures provided by Tony Levarchek, who, as all you know, I think, works in the Medical University of South Carolina. I worked closely with Tony for quite some time. And this is a beautiful picture where he is looking down on the aortic root. And there you see again that it is the right coronary sinus that overrides the crest of the septum. The entirety of the circumference of the aortic root is supported by the left ventricle. But what we have to do when the aortic root is overriding in the setting of a ventricular septum defect is to assess the degree of override according to the chord subtended by the septum relative to the overriding arterial root. In this instance, unequivocally, the normal heart, we have concordant ventricular arterial connections. But here is a comparable picture that Tony has made in the setting of Tetralogy of Fallot. Again, you're looking down on the overriding aortic root. The left side of the patient is to your left hand, the right side to your right hand. And there you see very nicely the crest of the muscular ventricular septum. And now, using these computed tomographic images, it is possible with precision to determine the proportion of the aortic root that is supported below by the cavity of the left ventricle, above by the cavity of the right ventricle. In this instance, we could say that the support is about 50-50 between the two ventricles, and so when it is in this situation, we will assign the aorta to the morphologically left ventricle, and we'll say that there are concordant atrioventricular connections. But we are going to assign the overriding root according to the proportion of its circumference that is supported by the right as opposed to the left ventricle. That is the key. As you see, this can now be determined with certainty when we have access to computed tomographic images. So here is another of Tony's exquisite pictures. Again, we're looking down on the base of the ventricular mass from above, the left side to your left hand, the right side to your right hand. And there, again, you see that the aortic root is overriding the crest of the muscular ventricular septum. But in this instance, the larger part of the aortic root, along with the entirety of the pulmonary trunk, are arising above the cavity of the morphologically right ventricle, meaning that in this situation, unequivocally, we have the ventriculo-arterial connection of double outlet right ventricle. So the emergence of these new techniques that permit us to assess the situation in 3 dimensions permits us with certainty now to arbitrate in the situation of overriding arterial trunks. So let's move now to the persisting controversy, how best to describe the channel between the ventricles. Now, if we simply call it a defect, we can go back to the seminal work that was produced by Maurice Lev and his colleagues in the early 1970s, when he pointed out that this channel between the ventricles could empty into the right ventricle in different positions. So in the majority of instances, the channel opens beneath the aortic root. So as Lev pointed out, we can call that a sub-aortic defect. Probably the second most frequent arrangement is when the channel opens beneath the pulmonary root. And that, of course, is akin to transposition. And there is a spectrum between this arrangement, when the overriding pulmonary root is mostly committed to the right ventricle, as opposed to the situation when the root is primarily committed to the left ventricle. And we can call this spectrum the Tausig-Bing lesion. And we're going to look at that as we will look at the other options established as possibilities by Maurice Lev. So the situation in which the channel can be doubly committed, or in some instances when the channel is non-committed. And we can now add to Lev's classification, because we now know that on rare occasions we can find double outlet right ventricle in the setting of an intact ventricular septum. So here is one of the examples of double outlet right ventricle with intact ventricular septum. This is one of the hearts from the Pittsburgh archive. I looked at this a long time ago. There is the aorta and pulmonary trunk. In this instance, they are separated by the muscular outlet septum, and both the aortic root and the pulmonary root are supported by completely muscular infundibulums. But in this case, there is no interventricular communication. There had been an interventricular communication initially, but it closed just prior to birth. And indeed, this heart came from an infant dying in the first week of life. And since then, we have found several examples with intact ventricular septum in the archives that, together with Diane Spicer, we've been looking at in Chicago, and also at the University of Florida in Gainesville, the Van Meerup archive. So on occasion, we can have double outlet right ventricle with intact ventricular septum. But in the majority of cases, there is a channel between the ventricles. And it remains the case that in most instances, people call this channel a ventricular septal defect. But is that really justified? So let me take you back, if I may, and show you the situation in Tetralogy fellow, and let's make comparisons between the area that is called the ventricular septal defect in Tetralogy and that area that most people call the ventricular septal defect in the setting of double outlet. And I'm going to do this again using the exquisite tomographic images prepared by Tony Levarchek and shared with me. So here you see a long axis cut through the sub-pulmonary outflow tract and the overriding aortic root in the setting Tetralogy. Left hand, you see the cavity of the right ventricle. There in the center of the screen, we see the overriding aortic root. To the top, we see the pulmonary trunk. And the essence of Tetralogy, as you know, is the malaligned muscular outlet septum, and it is exclusively located within the morphologically right ventricle, and it produces a squeeze with septoparietal trabeculations, giving us the narrow subpulmonary infundibulum that is the phenotypic feature of Tetralogy. But there is this space in the roof of the right ventricle that I think we all call the ventricular septal defect. Now, as you all know, the beauty of having these three-dimensional data sets is that we can rotate the cutting plane and we can see the images in any plane we choose. So what Tony has done here, he's rotated the cutting plane to show you the extent of overriding of the aortic root. And there now you see the long axis of the ventricular septum. And the ventricular septum, of course, interposes between the cavity of the right ventricle, the cavity of the left ventricle. If we continue the plane of the long axis of the ventricular septum, I can show you the geometric interventricular communication. Now, nobody is going to contemplate putting a patch along the geometric interventricular communication, because, of course, that would go to the underside of the valvular leaflets when the aortic valve was closed, to go to the underside of the aortic arch when the aortic valve was open. But that is the plane that separates the cavity of the right ventricle from the cavity of the left ventricle in geometric terms. But what we have when we have an overriding arterial root is we have a cone of space that is subtended beneath the arterial valvular leaflets to the crest of the muscular ventricular septum. And any area within that cone of space can be described as a ventricular septal defect. Indeed, it's arguable that it is the entirety of the cone that should be considered as the ventricular septal defect. But we need to consider the right and left ventricular margins of this cone of space. And I think it is generally accepted that it is the right ventricular entrance to this cone of space in Tetralogy fellow that is described as the ventricular septal defect. Irrespective of how we describe this space, it is the fact that that is the area that is closed by the surgeon so as to put the aortic root into communication with the cavity of the left ventricle. And in so doing, the left ventricular entrance to this cone of space becomes and is the outflow tract for the left ventricle. And nobody is going to contemplate closing this left ventricular entrance to the overriding aortic root. So it is the double-headed double-headed red arrow, I hope, which you will all agree is the ventricular septal defect. So let's now go back to the situation where we have double outlet right ventricle, and let's compare that situation in tetralogy with the arrangement where we have double outlet right ventricle with a sub-aortic defect. So this is what the heart looks like. Again, one of Tony's exquisite computed tomograms when we look at the septal surface of the right ventricle. There is the channel between the ventricles. You see the muscular outlet septum in double outlet right ventricle has in tetralogy of Fallot exclusively a right ventricular structure. Now again, being a three-dimensional data set, we can cut this channel in any plane, and as you see, it opens to the right ventricle between the limbs of the septomarginal trabeculation or the septal band. So let's cut it and let's look at the situation as we did in Tetralogy of Fallot. And now you see that in this particular heart, the aorta is exclusively arising above the cavity of the right ventricle. So there now is a cone of space subtended beneath the leaflets of the aortic root. And the cone of space is looking exclusively into the right ventricle. But we now need to recognize that the left ventricular entrance is the area that many people call the ventricular septal defect. But the point I make, it is not possible for the surgeon to close the left ventricular entrance to the aortic root. Instead, when the surgeon corrects double outlet right ventricle with sub-aortic defect, he or she tunnels the aortic root through the left ventricular entrance by placing a patch within the roof of the right ventricle. So it is the right ventricular entrance, as represented by the double-headed red arrow, that is the analog to the area we called the ventricular septal defect in the setting of tetralogy. And to my eyes, it makes much more sense also to call this area the ventricular septal defect in the setting of double outlet, because that is the area that will be closed by the surgeon so as to restore septal integrity. We can look at it again in the Taussig-Bing malformation. I've already told you this is the situation when in some instances we have overriding of the pulmonary trunk, but we can also have the Taussig-Bing arrangement when the pulmonary trunk arises exclusively from the right ventricle. And here in another of Tony's computed tomograms, we see that arrangement. Again, we have the cone of space that is subtended now beneath the leaflets of the pulmonary valve. And once more, it is the left ventricular entrance that provides the outlet for the left ventricle. And again, no surgeon is going to contemplate closing this space, which oftentimes is called the ventricular septal defect. And as in tetralogy, it is the right ventricular entrance to the overriding arterial root, or in this instance, the arterial root exclusively arising from the right ventricle, that is patched by the surgeon. In this instance, of course, it would also be necessary to do an arterial switch procedure. So if I put that all together and I take a pragmatic approach to the definition of double outlet right ventricle, I can say to you who are diagnosticians, is that if you ask the surgeon to close that right ventricular entrance to the arterial root, irrespective of what you want to call it, you must have determined for yourself that the patient had either concordant or discordant ventricular arterial connections, because you are going to have asked the surgeon to close the ventricular septal defect. Whereas in the setting of double outlet right ventricle, again, irrespective of what you're going to call the hole, if you decide there is double outlet connection, you are not going to ask the surgeon to close the hole. You are going to ask the surgeon to tunnel the defect to one or other of the outflow tracts. And it is that difference, whether you ask the surgeon to close the hole or whether you ask him to tunnel the hole to one or other outlet, that permits you to arbitrate the situation with overriding arterial valves. But put it another way, I do believe that when you determine there is double outlet right ventricle, it is better to consider a channel between the ventricles as the interventricular communication. So what is it that determines the location of that communication, which I recognize many of you call the ventricular septal defect? I hope I can persuade you to call it the interventricular communication, but we know it can take different locations. And the key feature here is recognizing the building blocks of the outflow tracts. What are those building blocks? Well, in the first instance, we have the outlet septum. In the setting of double outlet, that is going to be exclusively a right ventricular structure, and it is the component that interposes between the sub-aortic and sub-pulmonary outlets. The second building block is what we call the ventriculo-infundibular fold. This is the inner heart curve, and it is the part of the conus or infundibulum that separates and interposes between the hinges of the arterial valvar leaflets, the atrioventricular valvar leaflets. And then the third building block is the septomarginal trabeculation, or the septal band. In most instances, the D-channel between the ventricles opens to the right ventricle between the limbs of this entity, which is a muscular bundle that reinforces the septal surface of the right ventricle. And I can show you those building blocks very nicely in this particular heart. If you look at the subpulmonary outflow tract, you see there the phenotypic features of tetralogy of Fallot. But there is the muscular outlet septum, and we know that is the outlet septum because it is separating the narrowed subpulmonary outlet from the overriding sub-aortic outlet. I've chosen this particular heart because the cut shows you beautifully the ventriculo-infundibular fold. You see how it is part of the inner heart curvature because it is separating the hinge, the atrioventricular valve, in this instance the tricuspid valve, from the hinge of the pulmonary valve. And there is a very interesting point about this particular heart, because although it is tetralogy of Fallot, there is a complete muscular sub-aortic infundibulum. So this shows why you cannot use the presence or absence of a muscular infundibulum to make a phenotypic diagnosis, other than to say that in this heart there is a complete muscular subaortic infundibulum in the setting of tetralogy of Fallot. But there is the third of the building blocks, septomarginal trabeculation, and as you see, the interventricular communication in this particular heart is opening to the right ventricle between the limbs of the septomarginal trabeculation. So let's now look at a series of hearts with double outlet right ventricle, and let's look at the interrelationship between these building blocks. Now here is a classical example of double outlet. There to your left hand, you see the aorta. You're looking from the apex of the ventricle towards the base of the ventricle. So the aortic valve, in fact, is to the right of the pulmonary valve. In this instance, the arterial trunks are side by side. There is an extensive subaortic infundibulum, an equally extensive subpulmonary infundibulum. And there is the interventricular communication. Here we have the muscular outlet septum, exclusively a right ventricular structure, and you see that it is attached to the septomarginal trabeculation along its anterocephalad rim. And it is that attachment of the muscular outlet septum to the anterocephalad limb of the septomarginal trabeculation that places the interventricular communication in subaortic position. So this is an example of subaortic defect with bilateral infundibulums. Despite the presence of the bilateral infundibulums, however, there is fibrous continuity posterior-inferiorly between the leaflets of the tricuspid and mitral valves, and that means the conduction axis is going to be at risk at this posterior-inferior margin of the interventricular communication. Now, this is a fascinating heart. Again, we're looking at it from the right side, and again, we have the aorta to the right of the pulmonary trunk. But this time, despite the fact that the aorta is arising exclusively from the cavity of the right ventricle, there is fibrous continuity between the leaflets of the aortic and mitral valves. And this is one of the hearts that would surely give those who argue that the aorta is assigned to the left ventricle in the presence of aortic to mitral fibrous continuity, irrespective of its location above the ventricular mass. Because here, unequivocally, the ventricular arterial connection is that of double outlet right ventricle, and the interventricular communication again is opening to the right ventricle in subaortic position because the muscular outlet septum is attached to the anterocephalad limb of the septomarginal trabeculation. So there is the interventricular communication. The key feature, because of the presence of aortic to mitral fibrous continuity, the defect is much closer to the aortic root, which is arising exclusively from the morphologically right ventricle. So let's now switch tack and let's look at what happens when we have a sub-pulmonary defect. Again, you see that the aorta and the pulmonary trunk are side by side. In this heart, there's a subpulmonary infundibulum, there's a subaortic infundibulum, and there now is the muscular outlet septum. But this time it is attached to the inner heart curvature relative to the posterocaudal limb of the septomarginal trabeculation. The defect is still opening to the right ventricle between the limbs of the septomarginal trabeculation, but it is the fact that the outlet septum is now attached to the posterocaudal limb of the septomarginal trabeculation that puts the defect in subpulmonary position. In fact, although it is the outlet septum is attached towards the posterocaudal limb of the septomarginal trabeculation, there is still fibrous continuity between the leaflets, the tricuspid and mitral valves, so that once more the conduction tissue will be at risk when the surgeon is tunneling the interventricular communication into the pulmonary trunk before also performing the arterial switch procedure. As with the subaortic defect, however, we can also have the situation where we have a subpulmonary defect, again opening to the right ventricle between the limbs of the septomarginal trabeculation and placed in subpulmonary position, but this time with fibrous continuity between the leaflets of the pulmonary and mitral valves. So once more, because of the fibrous continuity, the defect is much closer to the pulmonary root. But it is the location of the muscular outlet septum attached to the midpoint of the inner heart curvature, in this instance with muscular continuity also between the caudal limb of the septomarginal trabeculation, the inner heart curve, giving and protecting the conduction axis. It is the location of the outlet septum relative to the septomarginal trabeculation that places the defect in subpulmonary position. So on occasion, you can find the situation in which the outlet septum is attached to neither the caudal nor the cephalad limbs of the septomarginal trabeculation. And it is that feature that then makes the defect doubly committed. So there, in this heart, you see the pulmonary trunk, Behind it, you see the aorta. The arterial trunks themselves in this individual were normally related. And as is usually the case, when the defect is doubly committed, we have a fibrous rather than a muscular outlet septum. Although on occasion, with this arrangement, you can have a muscular outlet septum. But the outlet septum now is attached to neither the caudal nor the proximal, the cephalad limb of the septomarginal trabeculation. So that makes the interventricular communication doubly committed, even though it opens to the right ventricle between the limbs of the septomarginal trabeculation, because the outlet septum is free-floating, if you like. The defect can be channeled either to the sub-aortic outflow tract or to the sub-pulmonary outflow tract. And in this instance, of course, the surgeon will choose to tunnel the defect into the sub-aortic outflow tract, leaving the pulmonary trunk arising from the right ventricle. And it is these hearts that on occasion can give the impression that the defect is in such a place that it is committed to both arterial trunks. So some would call this arrangement double outlet, both ventricles. In this instance, I think that the arrangement was such that the arterial trunks were committed mostly to the right ventricle. So we determined this one was double outlet right ventricle with a doubly committed defect. Note that there is a muscular bar posterior inferiorly, and that is protecting the conduction axis. Then, of course, we have the situation in which the defect can be non-committed. And in this heart, there's an exceedingly long sub-aortic infundibulum and a long sub-pulmonary infundibulum. And the defect is opening between the ventricular inlets. So again, there is fibrous continuity between the leaflets of the mitral and tricuspid valves, meaning that the conduction axis is going to be at risk posterior inferiorly. Some would argue, however, that in this instance, the interventricular communication could be patched into the pulmonary trunk. So it's arguable as to whether this should really be considered a subpulmonary defect or a non-committed defect. But in some instances, as in this particular heart, there is no question but that the defect is non-committed. There you see the aortic root with its infundibulum, the narrowed subpulmonary root with its infundibulum. And you see that the tricuspid valve is interposed between both arterial outflow tracts and the defect itself, which this time unequivocally is a ventricular septal defect because it's within the inlet component of the ventricular septum. Almost certainly there probably was a second defect in subarterial position, but that is closed. So here, without question, we have a non-committed defect. So the surgeon is going to want to patch, if possible, the interventricular communication to one or other of the outflow tracts so as to achieve surgical correction. What are the danger areas? So we come back here to the building blocks of the outflow tracts, because if we recognize the building blocks, we can tell whether or not incisions into them or resection of them courts danger. So I'm showing you the situation where the defect is subpulmonary, but the rules hold good, irrespective of the location of the interventricular communication. The outlet septum is safe and can be resected because it never carries the conduction system, but care must be taken not to damage the arterial valves arrayed at its distal end. The body of the septomarginal trabeculation is also safe, but that's unlikely to be involved in the outflow tracts themselves. It may be necessary to resect the anterior limb of the septomarginal trabeculation or the septal band, and that does court a degree of danger because lurking behind that anterior limb is the septal perforating artery. The major danger area, however, is related to the posterior limb of the septomarginal trabeculation, because that is where we find the atrioventricular conduction axis. It's at greatest risk when there is fibrous continuity between the leaflets of the mitral and tricuspid valves, oftentimes incorporating also fibrous continuity with one of the arterial valves, should there not be bilateral infundibulums. There is a degree of safety if a muscular rim is present posterior-inferiorly, but because that will protect the conduction axis. Then it may be necessary to resect the ventricular infundibular fold. That, as you will remember, interposes between the leaflets of an arterial valve and an atrioventricular valve. It is the inner heart curvature. You can cut through it, but remember, if you cut through the ventricular infundibular fold, you go outside the heart. You may find coronary arteries lurking there. If you recognize them, it doesn't matter. And if you know what you're doing, you can sew it up again, and so you can resect the ventricular infundibular fold. So recognizing the building blocks alerts you to the surgical danger areas. Now, don't forget the significance of arterial relationships. They do not, however, tell you what is going on within the heart. They will give you clues. So if the arterial trunks are normally related, you would anticipate the interventricular communication is either going to be sub-aortic or is going to be doubly committed. Oftentimes, the arterial trunks are side by side. In that setting, you get no clue as to what is going to go on inside. When, however, the aorta is anterior, then almost always the defect is going to be sub-pulmonary. But please, we should no longer be calling an anterior aorta transposition. Transposition nowadays should mean discordant ventricular arterial connections, and discordant connections cannot coexist with double outlet right ventricle. And rarely you may well find the situation in which the aortic root is anterior and left-sided. And typically in that situation, the interventricular communication will itself be beneath the aorta, meaning it is possible directly to tunnel the defect into the left-sided aorta. But the key point here, the arterial relationships do not make the diagnosis of double outlet right ventricle. They are one of the variables. So, what have I tried to tell you today? Double outlet ventricle is not an entity in itself. It is no more than one type of ventricular arterial connection, and we can put a whole host of different entities into this grouping. So we need full sequential segmental analysis to know what is going on and to make a precise diagnosis. Of the variables, without question, the most important is the channel between the ventricles. And I hope I've given you pause for thought, to think that this channel is better described as the interventricular communication, because it is exceedingly rare that we will close that channel. It is not like closing a ventricular septal defect. The only time it can be closed is if an alternative route is prepared for an exit from the left ventricle, because in the majority of cases, it is the channel between the ventricles that is the outlet for the left ventricle. It is an interventricular communication, and the key will be the possibility of channeling that interventricular communication to one or other of the ventricular outlets. And don't forget to look for other associated lesions. I haven't had time to share with you the array of associated lesions that can be found in the setting of double outlet right ventricle. The bottom line, it is one type of ventricular arterial connection, no more and no less.
Thank you very much, Dr. Anderson. It was amazing. It was very, very nice. We have a few questions from the audience. Josefa Paredes is asking about, she said she's making this question since literature seemed to only show the scenario that she's going to describe in the settings of DORF, but haven't seen any in the settings of VA concordance. So she's saying that, can I ask have you ever encountered a purely sub-pulmonic ventricular communication with a proeminent sub-aortic infundibulum? Pulmonary valve offset is lower than the aortic valve in the settings of normally related grand vessels. No sub-aortic infundibular stenosis.
No, I have never seen that arrangement.
Okay, very nice. Okay, then Ahmad is asking if in DORF with non-committed ventricular communication, what is the relationship between the defect and the septomarginal band?
That's a good question, because if the defect, this is where we get into the problem of distinguishing between a committed and a non-committed defect. And I try to emphasize that many surgeons, when the defect opens inferiorly to the inlet, between the inlet parts of the ventricles, that defect would be opening also between the limbs of the septomarginal trabeculation or the septal band. And that is the one where it can be very difficult to judge whether the defect is truly non-committed. The second heart I showed, however, had the defect opening inferiorly within the muscular septum. And I've also seen instances where the defect opens apically within the muscular septum. And that brings to the fore the question that has been posed, because in that setting, the defect would indeed no longer be between the limbs of the septomarginal trabeculation. So I think if you find a defect that is not cradled within the limbs of the septomarginal trabeculation, for sure, you can say that defect is going to be non-committed. The question then, should the other defects that do open between the limbs of the septomarginal trabeculation, should they always be considered to be committed? I think that is a decision that can only be made in the operating room. Perhaps now with computed tomography, with three-dimensional analysis, you can work out the feasibility the surgeon will have to tunnel the defect to one or other of the arterial trunks. And I think if the defect looks relatively distant, but the decision is made that it can be tunneled to one or other of the arterial trunks, then that should no longer be considered a non-committed. So the question is a very good one, and the relationship to the septomarginal trabeculation will give you that certainty that the defect is non-committed if the defect is no longer within the limbs of the septal band.
Okay, thank you. We have a live question from Now Miat Moon. You can open your microphone now. Or Naomi Gashara, if you want to open your microphone to make your question.
Okay. No, it was a mistake. I don't have a question now.
Okay, Naomi, thank you very much. So Elatafi, you can make your question.
Dr. Anderson, thanks for the lecture. Hello?
We can hear you. Go ahead.
In the setting of the double outlet right ventricle with the sub-pulmonic VC, I mean the Taussig-Benge heart, is there any anatomical relation between the anatomical relation of the great vessel and the coronary artery pattern?
Well, typically, if you have the Taussig-Benge setting, you will find either the aorta will be anterior or it will be side by side. If the interventricular communication is opening beneath the pulmonary trunk, then in that setting, there is the great possibility that one of the coronary arteries, the anterior interventricular artery, will cross the sub-pulmonary infundibulum to reach the anterior interventricular groove. So I think in that setting, you should always be looking for either the left coronary artery or the anterior interventricular artery to cross in front of the sub-pulmonary infundibulum. Of course, that's also the situation oftentimes in which the circumflex artery arises from the other coronary sinus and runs behind the pulmonary trunk. But even in that setting, still typically the anterior interventricular artery will cross the subpulmonary infundibulum. So that is always something that you should bear in mind. I didn't have time to discuss the problems that arise with the coronary arteries, but I noticed that one of the other questions that came up whilst the talk was still going on was the relationship in the Tausig-Bing malformation with transposition. And of course, that relationship depends exclusively on the proportion of the pulmonary trunk that is supported by the right versus the left ventricle. And if the greater part of the overriding pulmonary trunk is supported by the left ventricle, then in essence, we have transposition. And we all know that in that setting, oftentimes you have problems with the coronary arteries. So exactly the same problems that exist with the coronary arteries there are going to be found when we have the Tausig-Bing variant of double outlet right ventricle.
Thank you very much.
We have a question from Essam. He's asking about the whole of the papillary muscle of Lancisi in the in the definition of DORS and its related VSD.
But the papillary muscle of the infundibulum, the medial papillary muscle, the muscle of Lancisi, whatever you want to call it, is not a particularly reliable marker. Oftentimes, in fact, you have multiple small papillary muscles in that area, but all I can say is that typically the muscle of Lancisi arises from the posterocaudal limb of the septomarginal trabeculation or the septal band. So depending on the location of the defect itself, the relationship will vary relative to the muscle of Lancisi. And the muscle of Lancisi that does support the anteroseptal commissure of the tricuspid valve, so it's important in that regard. But as I say, it's not a constant landmark. And so it's another of these things, when it's there, you can take advantage of it. It's a landmark to the point of appearance in the right ventricle of the right bundle branch. So it is important in that regard. It does arise from the posterocaudal limb of the septomarginal trabeculation. So when there's a complete myocardial bundle posterior-inferiorly, that will also give you a key that the conduction axis will be relatively protected. So it can be important in that setting, but it's not a uniform marker. So that's why I didn't put much attention on the muscle of Lancisi or the medial papillary muscle.
Okay, Dr. Vera is here. She is asking, let me see, I lost her. Okay, so she's asking, she's thanking you for the presentation. And she's asking if in your experience, hearts with DORF and subaortic interventricular communication, but without the phenotypic features of fallow tetralogy, more frequently do or do not have fibrous continuity. Oh, Dr. Vera is here. Hi, Dr. Vera. Do you want to make your question live? We can hear you. We can hear you and we can see you, Dr. Vera. I think she doesn't hear. I think she doesn't hear us. What a pity.
Falo português.
Você consegue ouvir, doutora Vera? I don't think so.
She looks as though she's working.
Yeah.
With the mask. I should have my mask on to protect us from the virus.
Yeah, she says she has problems with connections.
What's the question?
So she was asking, Dr. Vera, now we can hear you. Okay, so she was asking about, so on the hearts with DORF and sub-aortic interventricular communication, but without tetralogy of follow phenotype, more frequently do or do not have fibrous continuity between the aortic and the tricuspid valve?
A very good question. I think that when you have a sub-aortic defect, whether or not there is a sub-aortic infundibulum, almost always there will be fibrous continuity between the leaflets of the mitral and tricuspid valve, so the conduction tissue will be at risk postero-inferiorly. We should never say never, but I think that when we look carefully at these hearts, then indeed we do find the fibrous continuity. And that was a bit of a surprise to us when we initially found it, because we had thought when there was bilateral infundibulums in this setting, there would be a muscular bar postero-inferiorly. But the more I look at them, then it's typically the case that there is fibrous continuity. So it's a very good question. And Vera will have been very interested in the presentation on the building blocks, because of course she was the first author when we published on the importance of the building blocks. And it's Vera who has in her archive a couple of hearts where, despite the defect being doubly committed, there is a muscular infundibular septum. And it's interesting in that respect that I've been working recently with Professor Iyer from India, and Professor Iyer, who now wants to call this double outlet both ventricles. And I think there's very good reason why this should be the case. And he's put together a series of 6 of these hearts where the arterial trunks, both of the arterial trunks, arise more or less equally from both of the ventricles. So he is making the point now that we should consider these hearts as being double outlet both ventricles. And Vera has hearts like that with muscular outlet septum. Typically they have a fibrous outlet septum, but we now know they can also exist with a muscular outlet septum.
Okay, thank you very much. I am lucky enough to have trained with her and had access to all of her hearts. It's a very beautiful collection, and she was making training courses to all of the fellows every year to show us that amazing collection. Okay, we have only one more question, so for the sake of the time. So Miguel is asking if in a patient with double right outlet, oh my God, with DORF, with sub-pulmonary VSD, is sub-aortic cone if it's always obstructive?
Not always, but again, it's much more usually that to be the case. Of the hearts I showed today, in fact, the sub-aortic area was not obstructed. But one of the features when you have the subpulmonary defect is that the infundibular septum, the outlet septum, tends to be deviated anterocephalad, and that does tend to narrow the subaortic area. And the other thing typically that goes along with that setting is straddling and overriding of the mitral valve. So these are the two. Again, I did not have time to discuss in length the associated lesions, but whenever you see a subpulmonary defect, you should always be thinking, as the question implies, is there narrowing of the subaortic outflow tract? And that, of course, goes with coarctation or interruption of the aortic arch. And then the other thing you have to be wary of is straddling and overriding of the mitral valve. And of course, straddling and overriding of the mitral valve is another of the features that can turn a potentially committed defect into a non-committed defect. And that also goes along with the subaortic defect, where you can have straddling and overriding of the tricuspid valve. So these are the features that are related to the associated lesions. I didn't have time to include all of those in my demonstration, so it's good that the questions come up, and that can also be brought into the limelight.
Okay, so we have one last question. So Dilashil, I don't know where is he from, saying that How do we avoid confusion for junior physicians regarding overlapping features of tetralogy of Fallot and Dorf?
I don't think you need to have that confusion,
Yeah.
because I think tetralogy, as I've tried to emphasize, is a diagnosis that depends upon the phenotypic morphology. You have to have anterocephalad deviation of the outlet septum. You have to have that squeeze with the sub-pulmonary infundibulum. So I think there need now be no confusion with stating that in that setting, the aortic root can be predominantly committed to the left ventricle, which is usually the case, or it can be predominantly committed to the right ventricle. And to me, there is no problem in that setting, having made the diagnosis of tetralogy, to say that this is tetralogy of Fallot with double outlet ventricular arterial connection. And this is the real point, because as I try to emphasize at the end, double outlet right ventricle is not a diagnosis in itself. You should no longer be saying the patient has double outlet right ventricle, because that's only telling a small part of the story. We must know, is there an interventricular communication? Most times there will be. To where is the interventricular communication committed? What is the relationship of the arterial trunks? Are there bilateral conuses? What are the associated lesions? So when you make the diagnosis of double outlet right ventricle, you're only scratching the surface. It's like the iceberg. You've seen that 1/7 or whatever it is of the iceberg that is above the surface, but all the danger is there below the surface, and it's those hidden parts that then need attention. So the diagnosis is but the start. For full description, we need to know all the other features of the heart of patients being put into the same ballpark of double outlet right ventricle.
Exactly, because without the associated lesions, we don't even can know how is going to be the clinical feature of this patient, right?
Absolutely, and that's the, as the last question emphasized, if you have a Taussig-Bing malformation and you have sub-aortic narrowing with coarctation or interruption, that's going to put a totally different picture than if you have an unobstructed sub-aortic outflow tract. Absolutely.
Perfect. Sasha, do you want to say something? I think we have to close up now. And thank you very much, Dr. Anderson. It was amazing as usual.